¿Qué es self-management? Bueno, pues la realidad es la capacidad de todo el mundo de cuidar su propia salud. Así que, por ejemplo, a mí me encontraron el colesterol alto el otro día, así que se pueden asegurar que yo no he comido nada frito, nada de carne, nada de queso. Estoy un poquito aburrida, pero es parte de mi self-care. Esto es particularmente importante para personas que tienen condiciones crónicas de salud, porque como sabemos, estas condiciones, si bien hay unos medicamentos que ayudan, lo que realmente transforma la salud de las personas son cambios en sus acciones, sobre todo cambios en sus acciones alimenticias, en sus rutinas de ejercicio y en su misma capacidad de tomarse sus medicamentos en el momento en que es necesario. Este componente del sistema de salud es uno que generalmente está bastante desprovisto, así que hay pocos sistemas que lo pagan y entonces, por lo tanto, tiende a ser bastante relegado. Y como es parte del cuidado que uno esperaría para que efectivamente las personas puedan manejar las condiciones, hay varias herramientas que se trabajan. Entre estas está la relación colaborativa entre el proveedor y el paciente. Así que generalmente cuando se está trabajando de self-management support y también de decisiones tomadas compartidas con los proveedores, una base de esos modelos son los planes individualizados de apoyo a esos pacientes. Hay muchos récords médicos electrónicos que tienen un modelo para hacer tu plan y hay unos checkmarks y la gente entiende que con eso ya el plan está hecho. Pero la realidad es que esto conlleva un poco más. Y muchas veces la manera en que están estructuradas las visitas médicas no se prestan para que exista el tiempo para entender bien por qué es que el paciente no está comiendo bien, por qué el paciente no está haciendo ejercicio y por qué no ha tomado las acciones que necesita para tomar su salud en sus manos. Algo que es fundamental para el desarrollo de estos modelos es en qué capacidad hay un equipo de trabajo trabajando con esos pacientes. Y si bien en nuestro sistema actual la relación paciente-doctor generalmente es una relación entre un paciente y un doctor, los modelos que trabajan con self-management support y con decisiones compartidas se tienen que trabajar con equipos suplementarios, con educadores en salud, con personas que sean trabajadoras sociales, que puedan también tomar en cuenta los otros factores que pueden estar afectando la salud de esta población, incluyendo temas como los determinantes sociales de la salud, pero más concretamente transportación, acceso a costo de medicamentos, vivienda y otras cosas hacia esos fines. Así que con las limitaciones que hay de contratar a otro personal para asistir en el cuidado de estos pacientes, es que entonces uno lo traemos como modelo para ver cómo se pueden trabajar esos modelos aquí en Puerto Rico. Otra cosa que está usándose mucho más, y la realidad es que yo no voy a tocar mucho en este tema porque está Juan Montañez por allá atrás, él va a estar trabajando el tema de Health Information Technology. Yo sé que el doctor hoy en su proyecto ha incorporado bastante de eso también. Hay varias herramientas que existen para apoyar en este tipo de relación. Como estaba hablando tan recientemente como hace unos minutos, allá atrás con la compañera que viene de Walmart, ellos están usando también monitores para que literalmente la información de diabetes de esos pacientes llegue y se pueda registrar en el récord del paciente. Y todas estas herramientas son importantes y lo chévere es que sabemos que son factibles y viables en nuestro mercado también. El tema de shared decision making es realmente en qué capacidad el médico generalmente le prescribe algo al paciente, pero de qué manera el paciente puede realmente ser líder en ese proceso de decidir qué es lo que necesita hacer. Esto es tanto como para el tema de los cambios que tiene que hacer el paciente en su salud, como para los tratamientos a los que decide o decide no participar. Eso incluye escogiendo sus medicamentos, cuáles medicamentos quiere escoger, qué procedimientos se acoge. Y se ha probado que tienden a ser bastante efectivos en la capacidad en que el paciente está bien informado, que siempre es un reto en el mercado nuestro. Como les habíamos dicho, esta es una introducción, el doctor va a hacer una presentación más detallada, pero si queremos ya puntualizar, y yo no me había dado cuenta que estos slides eran tan pequeños, pero a efectos de los estudios que han abarcado varios estudios ya, metaanálisis en Estados Unidos, sí se ha encontrado que generalmente cuando se incorporan estas metodologías hay un 5% de aumento en mejoría en la salud de los pacientes. 13% reporta más ejercicio. 21% reporta que hay menos depresión. 6% reportan que hay mejoramientos en la calidad de vida y 15% reportan que han perdido menos días de trabajo. Y 12% en que han perdido días de trabajo por problemas de salud mental. Así que la efectividad de estos proyectos, cuando hablamos de metaanálisis, eso quiere decir que se cogieron varios estudios, se compilaron y entonces el resultado sigue siendo contundente. No solamente son mejores para la salud de las personas, sino en costos también son bastante efectivos. Lo que se ha visto, y obviamente esto es con datos de Estados Unidos, es que el costo solamente de bajas en días que las personas están en sala de emergencia baja por 714 por paciente en este tipo de modelo y en promedio son 364 por persona. Aquí hay unas proyecciones que obviamente no son las nuestras, pero en Estados Unidos al implementar estos modelos se pudiese esperar como un 6.6 mil millones en ahorro de la implementación de los mismos. Con eso dicho, y ya concretamente, en Puerto Rico, doctor.
I'll walk it through. Good afternoon, ladies and gentlemen. Thanks Maria and Carlos for inviting me for this meeting. Although it came in a relatively short notice, I thought it was so important. Can you hear me well? Okay. Is that better? Okay. As you can see, I don't qualify as an entertainer, so. But I don't want to impose on you the touch of listening to me in Spanish, so I'm going to speak English. And that's because my Spanish doesn't qualify for decent conversation. But having said that, what I want to try and do this afternoon is to actually bring all of us back to where healthcare started, which is at the individual level. I realize that this is a policy meeting intending to look at the overall picture, but within that policy structure is the delivery. And the delivery is particularly important in Puerto Rico at this time in our own existence. And I see in this room the leaders that are responsible for creating a meaningful, clinically meaningful, economically meaningful, and socially meaningful outcome for this process. And this initiative, in fact, is designed to be able to help in that direction. And so I would sort of do a quick introduction because Maria had insisted that I do that, but I will very quickly hone down on how we have at least interpreted the difference between efficacy and effectiveness. And most of you who are involved in clinical research will understand that if you do a drug test, you do inclusion, exclusion criteria. By the time you finish, you have literally an experiment with pure circumstances, pure candidates, and so on. But being able to extrapolate that into the rest of the society means that we have to convert that to effectiveness. And effectiveness is heavily reliant on compliance. And all the factors, economic, social, all the cultural beliefs, systems, and so on that affect that translation of efficacy to effectiveness become the main reason why what we see in our published data in the journals do not always relate to what we see in real life. And for us, some kind of translational, call it type 2 translational research becomes very important. But I wanted to start off by trying to make sure that somewhere in there, everything we talk about has a value structure. That value structure depends on the perspectives. If you're an insurance commissioner, your perspective may be a quarterly EBITDA. If you are a physician who basically does a particular kind of surgery, your perspective may be limited to that kind of environment. So what happens around you and for the patient may not necessarily matter. In fact, sometimes it can be contraindicating to your own well-being. So in effect, what we need to do is to at least make sure we know that the perspective that matters is actually the patient, which is effectively a societal perspective. We must also align all the other perspectives for us to achieve the triad of good care, good economics, and clearly patient satisfaction. So if we cannot tie them together, then we will not achieve our goal. And that's why I put this slide there. And in effect, there's a point of departure, which is the patient. But none of us will accept to have a building, a commercial building, maybe our homes, built today without a blueprint. And so if we're going to provide a long-term management of a patient's care, then we ought to have a blueprint. And that's what care plans are. And I will come back and just show you what we've done in that process. But that's only one of the entities that or the tools that we use to try and create patient engagement in our program. So this is just a quick introduction. Next slide, please. But this is just to give you an idea as to what we're doing in Puerto Rico renal health and research. We do clinical studies, but we also do clinical care. And just to show you that in the last 5.5 years, we've had 17,000 patients come through, pre-diagnosed with renal disease. But we know that it's a drop in the bucket. Our estimation is that we have about 130,000 Puerto Ricans with advanced kidney disease, and advanced meaning stage 3 to 5. If you take every person who likely has renal disease, we're talking of close to 400,000. And the worst thing about it, which I'll show you in a few minutes, is that most of them don't actually know about it. So the burden of illness and the cost on the society is actually undefined. And because it's undefined, we will always never manage it properly. And so the need to define it, to create a secondary prevention and a tertiary prevention becomes extremely acute because of the cost that's involved. And I've just thrown those in just to show you the number of patients we've seen in our program. Our goal is very simple. We don't want people to go to dialysis. And if they must go to dialysis, we want to prolong it as long as possible. And I'll give you a good example. I'm a Canadian nephrologist. My practice was in Canada. If you had stage 3 kidney disease in my service, I have 8 to 10 years before you need dialysis. My experience in Puerto Rico was 18 months to 2 years. So that already tells you there's a substantial amount of potential gain that we can have simply by doing things correctly. And it's very simple. Most of those patients never saw nephrologists. They never had education. They never understood what it is until they ended up in hospital in acute illness and was told, your kidney is short, the kidneys are small, they're not going to recover, and now you're on dialysis. Next slide, please. And so in doing our program, we had to go back and say, okay, what are the challenges we must deal with? And I know you all know these issues, but they are necessary in the structuring of patient-centered care. What are the challenges? We have an aging population, and it's a peculiar aging process. The middle has been hollowed out. So it's not, if you look at the ratios, it is actually numerically okay, except that the ratios are much higher. We have a high prevalence of certain diseases, and that includes diabetes, which I think most of you know in Puerto Rico is somewhere around 2 times the average that we see elsewhere. And I can give you a perspective. In renal disease, 67% of Puerto Ricans that we see in renal disease are diabetic. In the US, it's about 40%. In Canada, it's about 32%. You go to Europe, it's about 28%. You go to Japan, you're down to about 17%. So first of all, we have the deck stacked against us. The same thing with hypertension. Not to the same degree, but substantial burden, public health burden of uncontrolled hypertension. And what we find is that there's a genetic predisposition for a rapid deterioration of kidney disease, which is actually very peculiar because those of you who know what happens to renal disease in the US, the blacks have the highest rate of progression compared to the Caucasian. And in fact, if you're a Mexican, your rate is just the same as a regular, what we call North European Caucasian. But if you come from from Dominican Republic, you're next to the black, and if you come from Puerto Rico, you're just right there. So, and I think it's genetic. The mixing of the genes and the survivor in the tropical environment means that you have to heal very rapidly. And most of the disease we see in kidney disease is actually a consequence of rapid healing when there's a damage to an organ. So as you go down, you can see all these changes. And so for us, the big challenge that we have today is actually medical manpower. We have 30% of what is needed as nephrologists to look after renal patients in the island. And to make matters worse, those 30% are functioning very inefficiently. Their time is consumed dealing with dialysis, which is end stage, too late, and no time left to prevent. And in that setting, we've created an artificial additional shortage to medical manpower. And I can tell you, and some of you know, every year there's 2 to 3 new nephrologists that qualify through a program. Half to 2/3 leave pretty well immediately. And some of that is simply because the reimbursement rate is too low. The US also has a shortage. And if you can get your American board, they'll pick you up any day and very quickly. So we have to find a way to deal with these issues. Otherwise, we're going to have a lot of people here who are not going to be able to be seen or looked after. So I'll just go to the next slide. And I just wanted you to understand, this is, we can go to the next slide. This is just an introduction. We've had this today, and it's just to repeat what everybody said, which is we must have a program that includes cost control. It must address optimal issues that are barriers, and it must be evidence-based. Next slide, please. And this is historic, just to show you that to develop this kind of thing does take time. And this is something that we've done essentially over the last 8 years to be able to get to where we are. Next slide, please. And I just threw this up to show you that in a period of a year, we did 26 health fairs to just look at what is happening, because we've not done a systematic cluster sampling of the society. But you go to churches, we have health fairs, and we're able to show, next slide, please, yeah, that of those people that we just randomly selected with history to screen, this is the framework we had. 41% had hypertension and diabetes together. 64% of those we selected for the testing had hypertension, and the rest were diabetic. Next slide, please. Next slide. And this is just to show you the total number of what we found. That in fact, of all these 3,000 or so tests that we did, and we were able to check with a finger prick your kidney function, this is the scenario, that a large number were already in stage 2 and didn't know it. None of these patients, by the way, knew that they had kidney disease. Next slide. And this is just the ratio. Next slide. So if you go beyond this now, next slide, this is the framework we use to plan our program, what we call the continuum of care, or the continuum of the natural history. Next slide. And the first thing in patient engagement is access. And this is to show you the different sites where we have clinics in green and the ones that are under planning. Next slide. And just to show that it does make a difference, this is the outcome of an 18-month pilot that we did, which, as you can see at the top, shows that we were able to reduce emergency room visits for this group of patients by 89%, and we reduced hospital bed days by 72%, and we were able to control blood pressure with an increase in control up to 70%. So all this shows us that this consistent effort actually led to good outcome. Next slide. So how do we do it? And this is the key issue. The patient needs to be engaged. And the patients don't get engaged because we tell them to get engaged. They have to be engaged by being immersed in the whole process. And so when we do care plan, we do it using a tool that we've developed that go systematically into the primary disease, the comorbidities, the complications, the medications, and we plan it as a multidisciplinary environment. And that care plan becomes a tool which we actually go through with the patient before it's signed off. So every member of the team gets the input, the physician signs off after the patient has and the family has gone through exactly what the plans are. And that information is then embedded in a card, which the patient carry with them. So if they are in hospital or they have to see a doctor, they can easily show what their plan is. But in addition to that, it is individualized, it's comprehensive, and as an indicator, it's updated as necessary. Next slide, please. And I would, if you don't mind, just show the video.
Las funciones de la aplicación de Care Plan. La aplicación comienza en la sección de búsqueda de pacientes. Los pacientes se pueden buscar ingresando el número de récord, el nombre o el número de teléfono. Oprimiendo el botón de Search for Patient o búsqueda, el sistema servirá una lista de pacientes que coincida con la entrada. Una vez identifique el paciente con el que va a trabajar, se oprime el icono de archivo a la izquierda del nombre. El sistema mostrará si el paciente está activo en algún Care Plan y dará la opción de crear uno nuevo. Al abrir un Care Plan, encontrará varias pestañas. Primero, en Problems, encontrará un listado de los diagnósticos del paciente y su fecha correspondiente. En la pestaña de RX, encontrará los medicamentos recetados al paciente, las dosis y fechas de comienzo y terminación. En Standards and Benchmarks, le brinda la información de los estándares que apliquen a la condición y los benchmarks establecidos por el proveedor. En las pestañas de Nurse, Dietitian y Social Worker, cada área está dividida en Metas, Assessment y Action Plan. Cada disciplina selecciona cada meta, action plan y assessment que aplique a cada paciente. El Care Plan provee para que cada profesional haga sus anotaciones. Las pestañas de las disciplinas pueden ser editadas según el programa de servicios del proveedor de salud que lo utiliza. En Status, el médico revisará todas las partes ya reportadas por cada disciplina, hará una revisión y hará cambios de ser necesario. Entonces escogerá el estatus de cada paciente entre Improving, Stable o Deteriorating. El médico selecciona cuándo desea revisar el Care Plan nuevamente entre las opciones de 90 días, 6 meses o 1 año. Finalmente, el médico firmará el Care Plan utilizando una firma digitalizada. Con su firma digital, el médico da por aprobado el Care Plan. El médico puede crear un reporte general presionando el botón de Report. Actualmente se está trabajando en un reporte específico para compartir información con otros proveedores de salud.